Yes, thank you for having me, first of all. My name is Nadia Alwasiah. I am a physical medicine and rehabilitation consultant. I am American board certified in physical medicine and rehab for adults, and I have American board certification for pediatric rehabilitation medicine. I currently work in American Hospital Dubai. I finished my education in King Abdulaziz University for medical school in Jeddah. I finished my residency training at Tufts Medical Center in Boston, the United States, and I finished my fellowship in Pediatric Rehabilitation Center um, at Spalding Rehabilitation Hospital, which is a Harvard affiliated school. My experience with spinal cord injury is, of course, um, extensive because this is pretty much what we do. So uh, we treat patients with spinal cord injury either on inpatient or outpatient basis. So after the acute injury, in the first few months, ideally the patients would come to us in inpatient rehab to maximize their healing, improve recovery, and have goals for recovery and independence when they go home as much as possible. Of course, depending on the level of the injury, whether it involved the neck, um, or the thoracic spinal level, or the lower back, which is the lumbar spinal level. So the other vignette where we see the patients is the outpatient clinic, and we see the patients for, of course, long-term follow-up. We see them for different problems that come with spinal cord injury, whether it's pain, muscle tightness, bowel, bladder issues, or even for overall functionality and quality of life. So most of the challenges is they have to do with community resources or just resources in general. So again, it depends on how high the level of the injury is. If it involves the neck, then it's going to affect the arm and the legs. If it involves the lower back, then it's only affecting the legs. And either way, the patient would need equipment. They may need wheelchairs. Of course, not everybody, but we're talking about the severe end of the spectrum of spinal cord injury. Um, Community support is very, very important because that's where the wheelchair accessibility comes in, maximizing independence with those individuals, giving them things that allow them to be independent as much as possible. Um, Knowledge about the challenges that they go through is a big, big thing, and knowledge of how to help them also. So these are the main things, and of course, understanding of the patient themselves about their condition, prognosis for recovery, what goals of rehab they have to achieve, and all of these things. So it's not the medical care itself that's challenging, it's the setting and the emotional aspects that come with it and the awareness. Of course. So rehabilitation, first of all, I have to say it's a multidisciplinary care. So not one person can manage spinal cord injury. It's usually a team approach. So the team is consistent of a rehabilitation physician, a physical therapist, an occupational therapist, an equipment provider, an orthotist, which is the person that does the splints, depending on the needs of the spinal cord injured patient. Again, if it involves the arm and the leg or the legs only. Um, some of the new things that are coming up for spinal cord, but it's still under research, is the spinal cord stimulator. It's still being studied. There are studies going on in Switzerland and in the US, and it seems promising, but it's not in clinical use yet. Otherwise, when we take the patient in the inpatient rehab, our goal is to maximize healing and recovery just by preventing the complications and allowing the body to heal itself. So especially in traumatic spinal cord injury. We follow the patient as they heal, and we progress their function as they are able. So we get to know the patient in the first couple of weeks, and then we determine what the goals are for discharge. How can we make this person independent again if we're not able to make them mobile or walking on their own? So once the patient comes to rehab, the entire team would assess them. Everybody would establish their goals, again, depending on how high the level is. Of course, some higher levels, the respiratory muscles are involved, so they need help with breathing. Some levels, respiration is preserved, but their arms are affected, and the legs are affected, and some only the legs. There are types of spinal cord injury depending on how complete or incomplete they are, and these are the classifications. So you have complete spinal cord injury where you have no signal going through from the brain to the limbs, and you have the incomplete where some of the signals are going through. So again, depending on the type and the level of spinal cord injury, we formulate the plan as a team and we execute it. As the patient is recovering and gaining movement, hopefully, then we start to work with them. Once you have a muscle twitch, you can start electrical stimulation. I found this very, very helpful. Also, weight-bearing devices. So the machines that help the patient get up and weight bear and attempt to walk, even if they're still not strong enough. It's just the maintaining weight bearing has so many benefits, and I'm a huge advocate for that, that even if the patient doesn't have the strength, we use the equipment to help them stand up for many good reasons, which is preserving bone health, maintaining gut health, and ease of respirations and all of that. And it's a passive stretch for the muscles as well. So these are the techniques and these are the things that we do in rehab. And then this is the inpatient part. Typically, the patient will stay in rehab around 3 months to 4 months. However, we're allowed to keep them. And then after that, they go to outpatient and they follow up on outpatient basis with our team, physical therapy, occupation, and myself. And we continue to monitor from there. Yes, a huge part, of course, because the patient needs all the support that they can get in this tough time. One of the major issues is mood and depression that comes after the patient is injured. Some people, more than others, of course, have a hard time coping. So managing this with medications can be a very important part. And, of course, education to the family. So throughout the rehabilitation process, we keep the families involved, we keep them educated, we explain, we involve them in any educational programs, and we always have updated family meetings. So if the patient, of course, with the patient's consent, we have to have the family there to teach them how to take care of this individual. Now with their new physiology, with their new ability, with their new function, teach them what support do they need when they go home, what support do they need when they go out into the community, how to get them back into work and life and everything. So family is very important in helping and supporting the patient with all of this. Of course, difficulty with coping and emotional distress is expected in this time. Initially, we try the conservative management. We offer support, we offer education. When the time is right, we start antidepressant medications, whichever is appropriate for that patient and they can tolerate. So the resource is usually having supportive support groups of people who suffer the same thing. I think this is a very valuable approach. For us, for our team right now, we keep a list of patients who have a spinal cord injury and are willing to come back and counsel the newly injured patients. This is very valuable, very important, and it really gives a good effect. Otherwise, our team establishes a resource center almost for the patients. So if they have any questions, if they feel they need to talk, we always have someone. Psychology is very important to have on board. Sometimes we need to involve psychiatry if the patient's depression is severe enough. And otherwise, yes, educating the family as well to how to provide the approach and comfort the patient while maintaining functionality and independence. Of course, the big topic is the complications or the physiologic changes that come with spinal cord injury. So the patients should know their new physiology and their new body. So there are things like autonomic nervous system changes such as autonomic dysreflexia, which is their body's way of telling them that something needs to be worked on or there's something hurting their body. Because if the patient has a complete spinal cord injury, then they don't feel what's going on below the level of the injury. So if there's anything pinching their skin, if their bladder is full and they don't know they need to empty it, then they have autonomic changes that causes a feeling of nausea, dizziness, and headache. So they need to understand when they feel that way, how to work on it and how to resolve it. That's the first thing. The other things are, of course, bowel and bladder care. So if their bowel and bladder, they're not working in the typical way, the neurotypical way, then we need to teach them, of course, understand that ourselves, and then we need to teach them how to maintain that as well on daily basis, to maintain continence, to maintain independence. So even if it's a child, they need to go to school continent, and for adults, of course, so they can go back to work without worrying about any of those accidents.